Thank you, Mark. That was excellent. Our next speaker is Olaf Christianson, and he's from Duke University, and he'll be talking about pediatric imaging and size-specific dose estimate at his institution.
It's my pleasure to be here today to talk to you about the size-specific dose estimate. I do want to acknowledge that this talk was originally scheduled to be given by Dr. Marilyn Goski, and she was unfortunately unable to attend, and I've used the majority of her slides. So I just want to acknowledge where they came from. To start with, we perform over 80 million CT scans every year. About 7 million of those are in children. This rise in the increase in CT utilization has led to an increase in the cumulative dose to the US population. And this is especially concerning for the pediatric population, where we know they're more sensitive to the radiation. Also, with the media today, everybody is reading about CT dose and how dangerous it can be. And parents are coming in and saying, what dose will my child get? We need to have one number that we're able to communicate to the patients and their parents, something that they can understand. Also, we have the need for a single metric to monitor radiation dose for local quality improvement, participation with dose index registries, and California law mandates that you record a metric of radiation dose. What's currently being used is known as CTDI-vol, which is measured using a 16 or 32 centimeter PMMA phantom. The problem with CTDI-vol is that you only have 2 phantom sizes, whereas our patients come in a broad ranges of sizes which may or may not be similar to the phantom that was used for the CTDI measurement. This plot illustrates how large this effect can be. Let's assume we have 4 patients with different sizes who receive the same imaging technique. The smaller patient will have a larger dose because they have less attenuation. CTDI-vol, however, has no knowledge of what size the patient is. So the CTDI-vol for these 4 patients would all be the same. This can lead to a significant underestimate of the dose to the pediatric patients. So just to summarize about CTDI-vol, it is a metric of scanner output. It is not dose to a patient. If you interpret it as dose to a patient, it can lead to underestimating the dose to pediatric patients by up to 300%. So to solve this problem, Task Group 204, TG204 was formed. TG204 consisted of research from 4 independent organizations across the US, 2 of which based their studies on physical phantoms, and 2 of which based them on Monte Carlo simulations. Each group measured the dose in the phantoms of increasing size and plotted the dose versus the phantom size. The plots were then normalized to give a value of 1 at a size of 32 centimeters. And when they did this, they found that the data tended to overlap quite a bit. So this is the actual data presented in TG204, and you can see that there's a pretty good agreement between the different data sets. It's also very well described by an exponential function. Using this exponential function, TG204 is able to generate tables, which you can use to look up a normalized dose coefficient. Now, there's 2 varieties of this table. One is if you use a 16 centimeter phantom for the CTDI-vol measurement. That's the table being shown here. And there's a second table if you're using a 32 centimeter phantom for the CTDI-vol measurement. Now let me walk you through the different columns of this table. The one on the left is if you measure the patient's size by taking the lateral and AP dimension and adding them together. Then you can look at this table and say, okay, my patient had a combined size of 20 centimeters, and I can look and find out that the correction factor for that one would be 2.59. I also can use just the lateral dimension, or just the AP dimension, or I can use what's known as the effective diameter. The effective diameter is a circle that gives an equal area to the patient, which is elliptical in shape. This can be calculated by taking the AP dimension, the square root of the AP dimension times the lateral dimension. TG204 also supplies us with a relationship between the AP dimension, lateral dimension, and effective diameter. So to determine the size-specific dose estimate, all we need is the body dimension, the phantom size, and the correct lookup table, as well as the CTDI vol. And I'm going to walk you through a couple examples of how you can use this. This is the first example. In this case, a scout image was used to measure the patient size. Here, the patient size was measured using the calipers on the machine to be about 15 centimeters, and a 32 centimeter CTDI vol phantom was used. So if you just look on the chart on the right, you go to the row for the 15 centimeter lateral dimension, and you find a correction factor of 2.29. You can then look on the scanner and find out that the CTDI vol, and you can multiply the CTDI vol by the correction factor to calculate the size-specific dose estimate. This can all be done before the scan is ever done. The technologist can do this on the scanner. Let me walk you through a second example. In this case, the CT images were used, and the benefit here is you can measure the lateral and AP dimension of the patient. So in this particular example, the CTDI vol was 5.4 milligray using a 32 centimeter phantom. The lateral and AP dimension were measured and added together and found to be 22 centimeters. So using this table where the lateral and AP dimension are combined, you can find for a 22 centimeter combined thickness, there's a correction factor of 2.5. So the SSDE can be calculated by taking the 5.4 milligray times 2.5, and we have a 13.5 milligray SSDE. Now this is a great, very simple, easy to use task group. The only problem with it is when you try to do it on a large scale. You can't have somebody measure every single patient that comes through, and for the dose index registry, there's thousands and millions of patients every day. So at Duke University, we've explored various techniques to automatically measure the patient thickness. This is based on the scout image, and we explored 8 different methods of varying complexities. To our surprise, the method that was found to work the best was the line profile method. And we found that on average, it agreed within 4% of measurements made by an observer measuring the patient thickness. So we can take the AP and lateral scout. If you only have one, you could just use one of the scouts. We measure the thickness using the line profile thresholding method and calculate an effective diameter. We then combine it with the equations from TG204 to come up with a normalized dose coefficient for every single patient that undergoes a CT scan. Let's take a look at how this impacts our data and data analysis. What I'm showing here is a scatter plot of CTDI vol. There's no patient size information accounted for here. And this looks similar to plots you may have seen before. And this is only pediatric patients, and this is an abdomen pelvis protocol. One thing you might notice is the horizontal lines here. That's caused because we have patient age and weight-specific protocols, so that leads to the stratification you see in the plot. The next thing I'm going to show you is a plot of SSDE. But instead of plotting just a scatter plot of SSDE, we have all the size information, so we plot SSDE versus effective diameter. And immediately you can see that more trends are apparent. In general, the dose to the patients increases slightly with increasing diameter, but there's a few outliers that are clearly identified now, and you might wonder where do they fall on the original scatter plot. Well, let's take a look at some of those. First, I want to direct your attention to the orange circle. This point was identified as a possible outlier without including size information. But then when we look at the plot of SSDE versus patient size, we find out that this patient was just a larger patient, and more dose was necessary to acquire the desired image quality. Far from being an accident, I would actually praise the technologist, because in this case, they actually increased the tube rotation time to make sure that we had an image with a low enough noise. The red squares indicate points that are clearly outliers when you look at the SSDE plot. However, may have been missed by looking at a scatter plot of CTDI vol. And finally, there's one point with the black circle around it that was identified using both methods. So while SSDE has, I think, clear benefits, there are some limitations I want to acknowledge. The first one is it assumes a water equivalent attenuation. This is a pretty good assumption for regions like the abdomen. However, it can be difficult in regions like the chest, where you've got the lungs with a different attenuation. Also, it might be difficult to apply to areas like the head, because we've got a lot of bones in the head. Second, and this is a point I think that some people are confused on a little bit, is SSDE is not organ dose. In fact, you might have a very different organ dose between the organs in the same study. It's going to depend on the organ size and location in the body. It's a step towards organ dose, but it is not organ dose yet. Third, SSDE is independent of organ sensitivity. This means that if you have the same SSDE to the breast tissue for like a chest scan versus SSDE to the abdomen, it could have very different effects on the patient. Fourth, SSDE is independent of age and gender. We know that younger patients are more sensitive to radiation. This is not accounted for by SSDE. And so the final limitation is sort of a combination of these. SSDE is not a surrogate for patient risk. Now, I've listed it as a limitation, but there are some people who would claim that this is actually a positive aspect of SSDE. As you no doubt are aware, risk has a lot of uncertainties associated with it, and it's very difficult to measure, especially in the low dose region, and it's very controversial. SSDE is grounded in something that we can measure. We can put a dosimeter inside a phantom. So this is a step towards patient-specific dosimetry, but perhaps not the final answer. Because of these limitations, we need to be careful about the language we use when communicating this information, especially to patients. TG204 supplies us with language that is recommended. Here they tell you to make sure to specify whether a 32 or 16 centimeter phantom was used for the CTDI vol measurement. They tell you to specify whether the AP lateral or sum of AP and lateral or effective diameter was used to measure the patient thickness. And then finally, they want you to acknowledge that there are uncertainties associated with this method of up to 20%. So to summarize, SSDE provides us with a relatively simple method to calculate patient-specific doses within about 10 to 20%. This is a major step towards patient-specific dosimetry. I think this is the most robust metric currently available. And like was mentioned earlier, I think SSDE will fix a lot of the problems people have seen in looking at the dose index registry data. More research is needed to move towards organ doses and eventually someday a comprehensive metric of radiation burden to the patient.